Good morning, everyone. This is Dr. Cindy Herndon, and I'm going to be presenting to you today Exemplar 15C, and we're going to be looking at chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease, or COPD, is a lung condition that is characterized by inflammation and progressive airway obstruction. Our exemplar learning outcomes today for Exemplar 15C. In order to analyze chronic obstructive pulmonary disease, or COPD, as it relates to oxygenation, we are going to describe the pathophysiology of COPD, describe the etiology of COPD, summarize the risk factors for COPD, compare methods for preventing COPD, identify the clinical manifestations of COPD, summarize diagnostic tests and therapies used by interprofessional teams in the collaborative care of an individual with COPD, differentiate care of patients with COPD across the lifespan, and apply the nursing process in providing culturally competent care to an individual with COPD. As earlier stated in the asthma exemplar, the exemplar on asthma, COPD is a lung disease that is characterized by inflammation and progressive airway obstruction, and the two most common disorders that fall into the COPD category are emphysema and chronic bronchitis, and very often these two disease processes coexist. While COPD is not curable, it is treatable and is managed with pharmacologic therapy and lifestyle change. Since emphysema and bronchitis often present together, it's hard to distinguish one from the other because the clinical symptoms may be similar. COPD is slowly progressive, and it is a disease that frequently is caused by smoking or occupational environmental exposures, injury to the lung tissue, systemic inflammation, and persistent airway limitation. The systemic inflammation leads to destruction of the airway passages, increased mucus production, narrowing of the passageways, obstruction of airflow, air trapping or decreased airflow with exhalation, and eventually hyperinflation of the lungs. And this course of events results in bronchitis or the inflammation of the bronchioles. The unequal changes in the airflow resistance leads to a VQ mismatch, retention of CO2, reduction of oxygenation, and then leads to impaired gas exchange. The pathogenesis of chronic bronchitis and emphysema are different. Both lead to obstructive airways, airway trapping, difficulty breathing, and persistent infections. Chronic bronchitis is a respiratory disorder that is characterized by edema, increased production of mucus, and bronchial inflammation. It is accompanied by productive cough for at least 3 months, with recurring episodes over 2 consecutive years. Cigarette smoking is a major risk factor in the development of chronic bronchitis. Emphysema is a pulmonary disorder that results in the destruction of the alveolar, the walls of the alveolar, and abnormal enlargement of air spaces and a significant limitation of airflow. The deficiency of alpha and antitrypsin, or AAT, an enzyme that normally protects the lungs from injury, is greatly reduced. The deficiency of AAT exposes some individuals to the development of emphysema. Some patients may experience a worsening of respiratory symptoms when exposed to the environmental irritants such as smoking, air pollution, and allergies, which contributes to the destruction of the alveolar walls. Once these alveolar walls are damaged, the alveolar the surface area decreases. Less space is available for gas exchange, and the lungs lose their elastic recoil, and air is trapped. The residual volume increases, and the destruction of lung tissue leads to alveolar collapse. Patients are taught the technique of pursed lip breathing, which involves exhaling through a narrow opening between the lips to prolong the expiratory phase that promotes more alveolar emptying while maintaining open alveoli. And this breathing technique creates a continued positive pressure and prevents further alveolar collapse. Asthma often coexists with COPD patients and patients who have a history of moderate to severe persistent asthma and may eventually develop COPD as a consequence of airway remodeling and destruction to the alveoli. COPD is included in the leading causes of death, disability, and illnesses in the United States. In many cases, the COPD patient has a 20-pack per year smoking history. With aging, the COPD worsens. Mortality rates are nearly equal among women and men, and COPD rates for women have increased significantly since 1970. In year 2019, the estimated healthcare cost for COPD patients was approximately $50 billion annually. COPD is not curable, but the symptoms are managed. Cigarette smoking is the major risk factor, and accounts for 80% of cases. Other contributing factors include exposure to environmental factors such as air pollution and coal mining, as well as other respiratory irritants. In patients with COPD, 1% of cases are linked to a deficiency of protein AAT produced by the liver, which is an inherited genetic abnormality, and this is referred to as a genetic COPD. AAT is necessary for normal lung development and function, so a lack of this protein causes pulmonary complications. Because lung damage from smoking is the most common cause, the majority of individuals with COPD develop the disease in adulthood, and the first symptom occurs by age 40 many times. The main risk factor for COPD is tobacco smoking. However, other environmental factors can also contribute, such as air pollution and coal mining. Environmental toxins, genetic abnormalities, abnormal lung development, and aging may predispose a person to develop COPD. Short and long-term occupational exposure to toxic chemical are risk factors also. An example is the dust that was created by the collapse of the World Trade Center towers in New York City in September 2001 resulted in the development of respiratory symptoms and chronic lung problems, and the effect was compared to 12 years of age-related deterioration in lung function. Current research suggests a persistent increased risk for the development of numerous chronic illnesses among those individuals, including asthma, COPD, and pulmonary fibrosis. The key to preventing COPD is to refrain from behaviors that have been linked with COPD. Stop smoking, or better yet, never start. Decrease exposure to secondhand smoke. Occupational respiratory irritants or air pollutants. This is especially important for Hispanic patients because they have an increased risk of developing COPD, and because tobacco use is the leading preventable cause of death among Hispanic populations in the United States. Studies suggest that Hispanics do not receive referrals for smoking cessation as frequently as other ethnicities. Another study indicates that smoking cessation brochures are sometimes not available in the Spanish language, therefore cannot be useful to Hispanic patients who do not read English well. Nurses should screen for use of tobacco and nicotine and provide teaching and appropriate referrals. Clinical presentation of COPD varies from simple chronic bronchitis without disability to chronic respiratory failure and severe disability. Forced expiratory volume in 1 second, or FEV1, is the amount of air that can be exhaled in 1 second as measured by spirometer. A patient's FEV1 reading combined with symptom manifestations determine the patient's level of COPD severity. On page 1126, box 14.4 outlines the classifications of COPD severity. COPD is a progressive disease characterized by 3 major symptoms, which include coughing, chronic coughing, persistent dyspnea, and sputum production. The symptoms tend to worsen over time. When the chronic cough and sputum production becomes intolerable, patients seek medical care. However, the symptoms often have been present for years at this point. Dyspnea is usually persistent, increases with exercise, and interferes with the quality of life. As COPD progresses, dyspnea may also occur at rest, and many patients may experience weight loss due to breathlessness worsening and interfering with the patient eating. Over time, the work of breathing increases and accessory muscle use is required to breathe. Chronic bronchitis and emphysema tend to coexist as COPD worsens. The primary characteristics of chronic bronchitis include a cough and thick, tenacious secretions, and these thick secretions that characterize chronic bronchitis affect the airways, obstructing airflow and gas exchange. As a result, oxygenation decreases, hypoxemia occurs, and arterial CO2 increases. Hypercapnia occurs, resulting in respiratory acidosis. Any person that experiences a chronic cough and sputum beyond 3 to 4 days should consult with a healthcare professional. Individuals with a smoking history and chronic cough with sputum production should have pulmonary function tests completed to determine their lung function. Emphysema is an alveolar problem that is characterized by loss of lung elasticity and hyperinflation of the lung tissues. These two changes in the lungs result in dyspnea and increased work of breathing. Dyspnea begins to happen upon exertion, but as emphysema progresses with air trapping and alveoli destruction, the dyspnea worsens. A cough may not be present. The anterior-posterior diameter of the chest wall increases as a consequence of this air trapping and hyperinflation of the lungs. And this leads to the development of barrel chest. That's what it is called when the chest looks like a barrel, and it happens with this disease process. As this process progresses, patients will begin to use their accessory muscles to breathe, and they will assume the tripod position, and that is sitting with a forward bending posture in order to breathe. During this time, breath sounds may be diminished, and percussion of lung fields may indicate hyperresonance, which is caused by excess air in the lung tissue. The patient may also exhibit pursed-lipped breathing in order to eliminate some of the air, and the breathing pattern may be tachypneic and rapid and shallow breathing pattern. Ineffective breathing patterns develop in COPD patients but can be diminished over time if patients are taught to practice deep breathing exercises known as diaphragmatic breathing. Diaphragmatic breathing is beneficial in reducing the respiratory rate, oxygen demand, and work of breathing. Patients should have frequent visits about every 6 months with their healthcare provider and/or pulmonologist because COPD will worsen over time. The providers will monitor decreased disease progression, current symptoms, effectiveness of treatment regimen, and current treatment modalities to care for specific needs of the patient. The increased work of breathing requires energy, and the energy requirement is intensified as the respiratory effort increases. Many patients will experience fatigue, loss of appetite, and have weight loss. The patient may also develop anxiety and apprehension, understandably. As COPD progresses in severity, it may impede oxygenation to other organs and tissues, leading to difficulty with activities of daily living and negativity, impacting the quality of life for the patient. Nurses will be assisted by collaboration of respiratory therapists, physical therapists, nutritionists, pharmacists, family members, and sometimes counselors to assist patients in achieving their desired outcomes and improve their quality of life. Nurses should be aware of who is caring for the patient with COPD who continues to live at home, and they should discuss with the patient and the family the need for the caregivers to have information and training so as to meet the care that provides best practice guidelines for the patient with COPD. Diagnostic tests are used to assist the healthcare provider in making a definitive diagnosis. The patient's clinical presentation and health history is also evaluated in assessing patients with known or suspected COPD. Pulmonary function tests are used to diagnose and determine the extent of disease severity and progression. Spirometry is used to measure the FVC, or forced vital capacity, and that is the amount of air exhaled forcefully and quickly after inhaling as much as you can. The normal value is 80 to 100%. And also the FEV1, and this again is a forced expiratory volume, and it measures how much air a person can exhale during a forced breath. The amount of air exhaled may be measured during the first FEV1 second, the second FEV2, and or the third FEV3 of the forced breath. Normal value for FEV1 is 70% and 65% for people older than 65. Serum AT levels are monitored to determine the presence of a deficiency. Chest x-rays are used to assess the presence of chronic disease and pulmonary infections. ABGs are monitored to assess baseline oxygenation and gas exchange. Pulse oximetry is watched for early indications of oxygen saturation. Complete blood count, or CBC, may be beneficial in detecting the presence of an infection. Hypercapnia is an elevated PaCO2 level, and this is often experienced in or seen in chronic COPD, and these people retain CO2. In these patients, administering oxygen can further increase the PaCO2, which contributes to worsening of the VQ mismatch, and this occurs when the ratio is not properly matched, resulting in ventilation perfusion mismatch or dead space ventilation. and it can be caused by pulmonary embolism, by asthma, by COPD, and interstitial lung disease, which is progressive scarring of the lung tissue, such as with asbestos, coal dust, autoimmune disease, rheumatoid arthritis, and this condition is irreversible. While oxygen is a mainstay of treatment for many patients with COPD, careful titration of oxygen is recommended. When the conventional therapies are ineffective in improving health status or quality of life, lung transplantation may be an option. Lung reduction therapy or the removal of the hyperinflated areas of the lung may improve gas exchange for patients. Endobrachial valve therapy, where a one-way valve is inserted in the airway to direct the flow of air from the diseased areas of the lung toward healthier areas, was approved by the FDA in 2018. Lung transplantation has been successful, but it is not frequently used because donor lungs are not readily available and are scarce. Among patients who have lung transplants, the 1-year survival rate is greater than 88%, and the 5-year survival rate is over 50%. Annual influenza vaccination is effective in reducing COPD exacerbations by decreasing the incidence of respiratory infections. Vaccinations against pneumococcal infections for people over age 65 is also recommended for all patients, especially those who are diagnosed with COPD, because these vaccinations reduce the incidence of pneumonia. When bacterial infections and purulent sputum are present, current COPD guidelines recommend antibiotics. Bronchodilators improve gas exchange and decrease the work of breathing and reduce the degree of breathlessness in the patients with COPD. Bronchodilators relax smooth muscles and widen the airway and allow for improved ventilation, but have no anti-inflammatory properties. As COPD symptoms persist, a long-acting beta agonist, or LABA, may also be prescribed in combination with a short-acting beta agonist. Theophylline, a methylxanthine, is used as a bronchodilator in COPD. As mentioned in the asthma lecture, it has a narrow therapeutic margin, so dosages may be carefully controlled. They must be carefully controlled. It may be prescribed for its ability to improve contractility of the diaphragm, which may result in decreased dyspnea and improved lung function. A short-acting muscarinic anticholinergic agent administered by metered dose inhalation, such as ipratropium, may also be prescribed. Combination therapy improves the desired effect and reduces adverse effects and has a longer duration of action. Corticosteroids are used to treat COPD because of the anti-inflammatory effect. Decreasing inflammation may improve pulmonary function and reduce episodes of dyspnea. It may also reduce exacerbations and hospitalization. A short-term trial of oral corticosteroids or prednisolone may be prescribed during acute exacerbations to determine if dyspnea decreases and pulmonary function improves. If the drug is effective, an inhaled corticosteroid is usually preferred to diminish the systemic effects associated with oral corticosteroids. Combination inhaled drugs such as Advair, Discus, Dulera, and Symbicort that contain long-acting beta agonists and a corticosteroid are helpful. Long-term use of corticosteroids in the treatment of COPD is not recommended because the systemic complications outweigh the beneficial effects. Expectorants such as guaifenesin decrease the viscosity of the mucus so that the patient can more easily expel it and clear the airway. Oxygen therapy may be long-term and continuous in severe COPD. The long-term administration of oxygen has decreased hypoxemia, reduced hospitalizations, and prolonged survival rates in patients with stable COPD. Oxygen therapy has been shown to decrease dyspnea, improve oxygen saturation, and reduce the work of breathing, and improve the patient's quality of life. And intermittent oxygen therapy is usually recommended for patients who desaturate during exercise while performing activities of daily living or during sleep. Oxygen therapy is usually low dose and delivered via nasal prongs. During acute exacerbation, higher concentration of oxygen is needed and required, and it's usually delivered in the higher rate via mask or intubation and mechanical ventilation. According to the hypoxic drive theory, patients whose blood CO2 level remain chronically elevated, such as patients with COPD, develop a decreased response to hypercapnia. So the body adapts. Percussion is a rhythmic movement of the chest wall with the hands in a cupped position. Fingers and thumbs are slightly bent and the hand is flexed as though trying to scoop up water. Percussion is performed over several areas of the chest wall, and if performed correctly, a hollow popping sound should be heard. And this percussion of congested lung fields helps to dislodge and facilitate the movement of thick mucus. The cupped hands should create a pocket of air between the chest wall and the hand that helps with the movement of secretions into the central airways. Avoid percussion over the kidney, the breast sternum, and the spinal column. Vibration is a rapid pulsating movement generated by the palms of the hands when placed against the chest wall during exhalation. And this vibration therapy facilitates movement of the secretions into the larger airways. The chest vibrations are alternated with percussion. Postural drainage uses gravity to drain secretions from different lung segments while alternating positions. The various positions depend on the area of the lungs affected and the segments of the lungs to be drained. During each position change, the patient's chest is lower than the hips to promote drainage of the secretions, and each position is maintained at least 5 minutes. This technique is recommended an hour before meals or 2 hours after meals to decrease the chance of vomiting. Bronchodilators and hydration may be prescribed prior to postural drainage to loosen secretions, and this is often prescribed 2 to 4 times daily or more if necessary. The secretions that are not cleared may result in obstruction, bacterial growth, and subsequent infection. A pulmonary rehab program is an individualized, supervised outpatient program that assists patients with lung problems to improve the quality of their life. The program provides educational information on medication use, action and side effects, use and understanding of oxygen, the importance of adequate nutrition, diet and weight management, exercise training, strategies to cope with and manage breathing problems, and symptoms that require medical intervention. Since smoking is the top risk factor in developing COPD, Abstaining from smoking is so important. Smoking cessation reduces the likelihood of lung function decline and impaired cilia movement if COPD is diagnosed. When patients refrain from smoking, breathing is improved and the amount of air exhaled during a forced breath, or FEV1, is also increased. The patient is also trained to avoid other respiratory irritants such as smoke, dust, smog, and the patients are taught to remain indoors when air quality is poor. Exacerbations are decreased and breathing is improved when adhering to this recommendation. Air filtering systems can be used in the home and filters are changed every 6 months. The use of cough suppressants is discouraged. Exercise is considered a part of the therapy unless it is more of a risk than a benefit. Exercise may be beneficial in decreasing breathlessness and strengthening the respiratory muscles and improving physical endurance. If implemented, the patient needs to be encouraged to maintain the exercise regimen. Physical inactivity may result in increased hospitalizations, exacerbations, reduced quality of life, and premature death. Breathing techniques, as mentioned earlier, are helpful. Hydration is important to assist in thinning and expectorating the respiratory secretions and to maintain an overall fluid volume balance. A low sodium diet is recommended to prevent water retention. Recommended fluid volume intake must be taken into consideration, and coexisting conditions, for example, heart failure and renal disease. That is very important in taking into consideration the fluid intake. Humidity prevents drying of secretions and makes it easier to cough up the mucus and expectorate that mucus. Humidifiers moisten the air and may reduce dryness of mucosal membranes, and it is important to maintain cleanliness of the humidifiers to reduce bacterial growth. It's very important. Nursing care is focused on promoting oxygenation. Health promotion includes smoking cessation, reducing risk for infection, and maintaining patient safety. Because of the chronic nature of the disease, patient teaching on maximizing self-care is so important, as well as knowing when to notify the healthcare team. A focused patient assessment for the patient with COPD includes collecting data on current symptoms, general appearance, mental status, and pursed lip breathing. Assess for tachypnea, tachycardia, use of accessory muscles, cough, sputum production, breathlessness, frequency of respiratory infections, exacerbations, and activity tolerance. Note the patient history of respiratory diseases. Document current medications and their effectiveness to alleviate symptoms. Note the recent or past exposures to environmental and occupational irritants and smoking history and PAC years. Place the patient in a position that provides maximal lung expansion and ease of breathing. Assess the anterior-posterior diameter of the chest wall and check for barrel chest. Vital signs are checked. Use of accessory muscles and weight in relation to the height, or this is the BMI. Auscultate the breath sounds and monitor oxygen saturation levels. Measure diaphragmatic excursion, monitor peripheral pulses, and assess for edema. Auscultate the heart rate and rhythm for irregularity and the presence of extra beats. You may note adventitious lung sounds, wheezes or crackles, although most often lung sounds are diminished. S1 and S2 heart sounds may be difficult to distinguish in the presence of a barrel chest, which tends to exist when there is an increased anterior-posterior diameter, particularly with patients who have been diagnosed with emphysema. And the nurse should inspect the chest for symmetry upon expansion. Percussion of the chest wall may result in hyperresonance, which implies the presence of excess air in the lung fields. And many people with COPD may become unable to live independently and carry out their activities of daily living or improve the quality of their lives. A home health care assessment to determine if the patient's need for oxygen may be warranted. Patients diagnosed with COPD have several nursing care concerns. Maintaining a patent airway and adequate gas exchange is a priority. Inadequate nutrition is also a common problem. Fatigue, shortness of breath, and anorexia are some major symptoms. An inability to adequately care for oneself affects patients psychologically, and this will be taken into consideration in the development of the nursing hypothesis. Needs will vary from patient to patient, but may include ineffective breathing pattern, impaired airway clearance, inability to tolerate activity, weight loss, inadequate family coping skills, and difficulty making the decision to stop smoking. Nursing care of the patient with COPD requires comprehensive planning to meet the patient's primary need of adequate oxygenation. Possible outcomes may include the patient will maintain a position that promotes maximum lung expansion. The patient will maintain an airway free of secretions. The patient will experience decreased work of breathing and decreased episodes of breathlessness. The patient will be taught pursed lip breathing to assist in decreasing respirations and promoting relaxation. The patient will maintain an oxygen saturation of greater or equal to 90%, and the patient will maintain vital signs within normal limits or baseline levels. The highest priorities of nursing implementation are aimed at promoting oxygenation, which includes monitoring and promoting airway clearance and effective breathing patterns. Ongoing reassessment will be necessary to evaluate the effectiveness and your interventions. The nurse will teach and assist with techniques to control and improve breathing patterns of pursed lip breathing, diaphragmatic breathing, and relaxation techniques. As mentioned earlier, chronic bronchitis and emphysema often coexist, and both result in airway problems. In chronic bronchitis, the thick secretions obstruct the airway and impair gas exchange. In emphysema, the destruction of lung tissue, loss of elasticity, and the enlargement of the alveoli increase chances of alveolar collapse and further gas exchange impairment. With both conditions, more CO2 is retained in the lungs, decreasing the availability of oxygen in the alveoli for gas exchange. The cilia in the lungs function less efficiently, resulting in more bacteria, respiratory infections, and possible increase in exacerbations. In order to work to prevent poor outcomes, the nurse will promote airway clearance through the following procedures. Encourage fluid intake of 2,000 milliliters or more per day unless contraindicated. Place in the Fowler's, high Fowler's, or orthopneic position. Monitor arterial blood gas ABG results. Assess respiratory status every 2 hours or more as indicated, and auscultate lung fields every 4 hours. Also monitor daily weight, intake and output, skin turgor, mucous membranes, and deep breathing and coughing every 2 hours. Provide tissues, paper bag, or disposals. Refer to the respiratory therapist for chest physiotherapy and assist or perform as needed, administer expectorant bronchodilator medications, and provide supplemental oxygen as ordered by the physician. In COPD, many patients are underweight and malnourished, and it requires considerable energy and strength to consume a meal without experiencing fatigue and difficulty breathing. In addition to the increased expenditure of energy, the patient experiences dyspnea and decreased oxygenation saturation. As a result of all of this, the patient eats less, is nutritionally malnourished, and appears thin and emaciated. The process weakens the immune system and places the patient at increased risk for infection. The nurse will assess nutritional status, diet history, food allergies, BMI, and existing comorbidities that may compromise nutrition. All of this information will serve as a baseline selecting a diet that meets the metabolic and nutritional needs of the patient. The nurse would promote balanced nutrition by assessing nutritional status and observe and document food intake and monitor lab values, consult with a dietitian, and maintain a food log. The nurse will provide frequent small feedings and between meal snacks. The patient will need to be placed in a seated or high Fowler's position for meals, assist to choose preferred foods with the patient, and encourage family members to bring food from home if allowed. Provide mouth care before meals. If a patient cannot maintain oral intake, consult with a primary care provider in regard to internal or parenteral feedings. Chronic illness creates a tremendous stress and burden on families. There is often a change in roles and relationship as a consequence of the illness. Family members may have difficulty adjusting to new roles and experience anger, frustration, or resentment toward family members who are ill. Others may take on the responsibility with ease and appreciate the opportunity to care for their loved one. The person who is ill may have difficulty adjusting to the loss of independence, causing a sense of powerlessness, depression, and despair. The nurse would promote family coping by encouraging the patient to accept the need of assistance, assess the effect of illness on the family, and provide information and teaching about COPD. Encourage the family to refrain from smoking or using tobacco products in the home. Initiate care conference involving patient, family, healthcare team members, and provide information on community resources. Refer the patient for support groups, family support groups if necessary, if needed, and pulmonary rehabilitation programs. The nurse would carefully monitor the patient's rate and depth of breathing, along with the heart rate and the blood pressure, and this is an important evaluation measure of the nurse. The baseline data will be compared to the patient's present status to note changes and determine if there is a need for concern. The nurse would assist the patient in developing realistic goals to meet a desired outcome. For example, improving the ease of breathing may occur readily with a change in the medication regimen. Quitting smoking may take longer to accomplish. Potential outcomes may include patient consistently maintains O2 saturation at above 90%. Patient modifies activities of daily living to reduce fatigue related to activity intolerance. Patient follows an exercise program to increase endurance and decrease dyspnea. Because COPD is chronic, the patient will need continual re-evaluation. Patients who smoke may need multiple attempts before successfully quitting smoking. The nurse should evaluate the patient's progress and provide encouragement with each interaction. And small steps are worthy of celebration. Now we have some questions, some practice questions for you. Question 1. A client has been hospitalized in the respiratory intensive care unit because of an acute exacerbation of chronic obstructive pulmonary disease, or COPD. Arterial blood gas analysis of the client's 3 samples from earlier in the day show increasing hypoxemia and hypercapnia. The nurse will observe the client closely for what indications of impending respiratory failure. Your options are number 1, increased expectoration of sputum, number 2, decreased heart rate, number 3, increased respiratory rate, number 4, decreased level of consciousness. The correct answer is number 4, decreased level of consciousness. And the rationale for this question, number 1, for this answer of question number 1, is increasing hypoxemia and hypercapnia, a decreased level of consciousness, cyanosis, or worsening of airway obstruction indicates respiratory status is deteriorating. The nurse should prepare for intubation and mechanical ventilation. Respiratory failure is a possible complication for this client, and immediate intervention is required to preserve the client's life. The client would experience decreased expectoration, increased heart rate, and decreased respirations. Question number 2. A client with an exacerbation of chronic obstructive pulmonary disease, COPD, is admitted to the acute care unit. The client is experiencing dyspnea on exertion and states that it is becoming more difficult to breathe. In order to plan care, the nurse interprets the client's signs and symptoms as indicating which stage of COPD. Your choices are number 1, gold 1, number 2, gold 2, number 3, gold 3, number 4, gold 4. And the question to answer is number 2, gold 2. The question rationale, or the answer rationale, is gold 1 is mild, and it shows mild airflow limitation. Gold 2 is moderate and adds worsening airflow limitation and dyspnea on exertion. Gold 3 is severe, and it adds increased shortness of breath and repeated exacerbations. Gold 4, very severe. Exacerbations are potentially life-threatening. Question number 3. The nurse is teaching effective breathing techniques to a client with chronic obstructive pulmonary disease. Which statement would the nurse use to explain why dyspnea occurs? Your choices are number 1, decreased surfactant causes many of your alveoli to collapse. Number 2, you have difficulty breathing in enough air. Number 3, your airways open wider on inspiration and trap air on expiration. Number 4, your lung compliance is decreased. And the answer to question 3 is your airways open wider on inspiration and trap air on expiration. The rationale for question 3. The primary physiological alteration occurring with COPD is alveolar air trapping and alveolar hyperinflation, which lead to alveolar rupture and loss of area availability for gas exchange. Decreased surfactant production is associated with ARDS and is not a primary alteration of COPD. Lung compliance is decreased, but this is a result of alveolar trapping and hyperinflation. Question 4. The nurse determines that which goal is an appropriate goal for a client with an acute exacerbation of chronic obstructive pulmonary disease, or COPD. Your choices are: number 1, client will verbalize self-care measures to regain lost lung function. Number 2, arterial blood gases will be within normal limits by discharge. Number 3, client will maintain oxygen saturation of 90% or greater. Number 4, client will identify strategies to reduce the number of cigarette smokes per day. Your correct answer for this question, number 4, is number 3, client will maintain oxygen saturation of 90% or greater. And the rationale for that answer is during an acute exacerbation of COPD, maintaining oxygen saturation of 90% is an appropriate goal. Lost lung function cannot be regained, and blood gases will never be within normal limits. Any amount of smoking is not an option for a client with COPD. Question number 5. Which finding would be expected in a client with chronic obstructive pulmonary disease, or COPD? Your choices are: number 1, anterior-posterior AP chest diameter equal to or greater than lateral chest diameter. Number 2, mental confusion and lethargy. Number 3, pitting edema of ankles and lower legs. Number 4, oxygen saturation of 85% or less. The correct answer for question 5 is anterior-posterior AP chest diameter equal to or greater than lateral chest diameter. And the rationale for this answer is development of a barrel chest due to air trapping is an expected finding of COPD. Confusion, lethargy, and low oxygen saturation levels indicate respiratory failure. Pitting edema occurs with heart failure. Question 6. The nurse should counsel the parents of a child with asthma that before performing postural drainage exercises, the parents should perform which action? Question 6 choices. Administer the bronchodilator. Number 2, change the child's clothing. Number 3, administer an antibiotic. Number 4, section the child. Question 6 answer. The correct answer is number 1, administer the bronchodilator. And the rationale for this answer is bronchodilators open the airways and allow for easier removal of secretions. Changing clothing and giving the antibiotic are irrelevant to the procedure. Suctioning is done after postural drainage if the child is unable to cough up secretions. Thank you for viewing this video and listening and taking notes. Hopefully you've taken notes, and I look forward to you being in class, and we will have an unfolding case study in regard to these disease processes. Thank you so much.